Welcome students. Today we are going to discuss on the topic an overview on maternal health, the antenatal, intranatal and postnatal care. I am Dr. Barnali Ghosh, an obstetrician and gynecologist, presently working as an assistant professor at B.C. Roy Medical College and Research Center, IIT Kharagpur. Today we are going to deal with a very important topic, that is the anatomy of vagina. Coming straight to the topic, the concepts covered are anatomy, the relationships of vagina with the adjoining pelvic structures, detailed structure of vagina, the cytology of vagina and its clinical importance, the pH maintenance of the vaginal epithelium, the vaginal fluid, the flora or the commensals, the bacteria which reside in vagina, thereby helping in vaginal defense, and ultimately we will touch upon little bit on vaginal cancer. This is a pictorial representation of the female internal as well as external genitalia, shows the uterus, the ovary, the fallopian tubes and the cervix, and from here is the starting point of vagina. Vagina is actually a cylindrical structure. Anteriorly is the urinary bladder with the urethra. This is the ureter, this is the urinary bladder, this is the urethra. This is the ovary, the fallopian tubes, the uterus, the vagina, and this is the vaginal opening, and behind will be the rectum, ultimately opening as the anus. So, what is vagina? Vagina is a fibromuscular organ. Vagina is a fibromuscular hollow cylinder, and it is attached to the middle of the cervix. The posterior wall, this is anterior, this is posterior. So, I will draw it again for you. This is the cervix and this is the vagina. So, this is anterior, this is posterior. The anterior wall is slightly shorter than the posterior wall. Posterior wall is longer. Posterior wall is longer. Length of the posterior wall approximately 9 centimeter. Length of the anterior wall approximately is 7 centimeter. And if we take a cut section, this is the vaginal epithelium and this is the vaginal lumen. If we take a cut section, it is in the form of H. This cut section, this portion is in the form of H. So, vaginal lumen, actually this is showing the vaginal lumen. this is in the form of H. Now coming to the fornices of vagina. This is the cervix and here is the vagina. So, from below there will be all around there will be dead spaces around the cervix. The cervix is ending and the vagina is all around. So, all through will be the dead spaces and these are known as the fornices. So, space around the cervix and the upper part of vagina is called as fornix. How many fornixes are there? There are 4 fornices: anterior fornix, posterior fornix and 2 lateral fornix. What is the deepest fornix? It is the posterior fornix, deepest. Shallowest fornix is the anterior fornix. And a very important question is what fornices are present after total hysterectomy. Total hysterectomy means removal of the uterus together with the cervix. Cervix is also removed. In that case, if we remove the cervix, what remains are these vaginal walls, which will be sutured. This walls will be sutured. Now, after the removal of cervix, number of fornices present is 0, no fornices. But in case of subtotal hysterectomy, what is subtotal hysterectomy? That is, the cervix is present. Cervix is present. From here, the uterus and the uterus has been removed. Where it is done? It is done in case of atonic PPH. PPH is a very emergency situation where there is immense bleeding, postpartum hemorrhage after childbirth, when there is immense bleeding from the uterus and it is not being corrected with medication, with different types of suturing, with different mechanical devices, compression sutures, and you have to save the life of the patient. Then we go for the hysterectomy, obstetric hysterectomy as a last resort, where we remove the uterus, but because bleeding is from the uterus and it is not from the cervix, and to minimize the time of operation, the cervix is kept in situ. In that case, the number of fornices are 4. After subtotal hysterectomy, number of fornices is 4. Next, the relations of vagina. As I have earlier, in that at first there was a picture showing the anterior relations of vagina. Again, I will draw that picture. This is very interesting and very important to know, because during childbirth there can be vaginal injury. During cesarean section, you have to go through different you need to know the anatomy very thoroughly so as to do the operation meticulously. So, anteriorly this is anterior and this is posterior. So, this is the anterior vaginal wall. Upper two-third is related to the urinary bladder. This is the urinary bladder. So, upper two-third is related to the urinary bladder and lower one-third is related to the urethra. this is the anterior vaginal wall. So, during prolapse, when there is sagging down of the pelvic organs through the vaginal opening, if the anterior 2/3 sags down, then there is descent of the urinary bladder, or if the lower 1/3 sags down, then there is descent of urethra. The posterior vaginal wall, how it is related? I will use a different color. This is the peritoneal covering. Peritoneal covering. It is covering the urinary bladder, and there is a very loose fold of peritoneum covering the urinary bladder and the uterus. Uterus, it is uterus will be covered anteriorly. It will cover the uterus, but not the vagina. Anterior part of the vagina, anterior vaginal wall, there is no peritoneal covering. Then it will go over the fundus and then to the posterior surface, then the posterior aspect of cervix, then the posterior vaginal wall, and then it will revert back or reflect upwards into the abdomen. This is known as the pouch of Douglas or the cul-de-sac. It is the most dependent part of the female peritoneum. Any pus, any collection, any ascites, any blood will be collected in the POD. So, posteriorly, the upper 1/3, here are the intestines. So, posteriorly the upper 1/3 is covered with peritoneum, and there comes in relation the pouch of Douglas, upper 1/3. Then middle 1/3. Middle 1/3, behind is the rectum. Middle 1/3 comes in relation to rectum, and lower 1/3, this is the anus. It comes in relation to the anus, but it is separated from the anal opening by the perineal body. So, I hope it is clear. Upper 1/3, middle 1/3 and lower 1/3. Any stitch, any surgery, any pelvic floor repair involving the posterior vaginal wall, we have to be very meticulous to prevent injury to rectum and anus, which comes in the posterior relation. Now coming to the vaginal wall epithelium. Now vaginal wall, this is the vaginal one side, this is the lumen, then again other side, this is a hollow cylindrical structure. So first is the epithelium, then is the muscle and the condensed endopelvic fascia. What is this epithelium? Vaginal epithelium is stratified squamous epithelium, non-keratinized, and very importantly, it does not have any glands. There are no glands. So, where does the secretion of the vagina come from? They come from the transudate, from the cervix. The endocervical gland secretion, come to the vagina. As such, vagina does not have any glands, right? This is also important in, I will discuss it in subsequent slides. Coming to the supports of vagina. This is I have already shown you the picture. This is the urethra, this is the vagina, and behind is the anus. So, vagina has to be supported, it has to have some support, or there will be more chance of prolapse, more chance of descent of pelvic organs through the vaginal opening. What are the supports? There are three steps, three layers of support. De Lancey's layer, De Lancey's layers of support. What are they? Level 1. Level 1. What is it? It is the apex of vagina. Apex of vagina. Apex of vagina is supported by number 1, the cardinal ligament or the Mackendorf's ligament, which is present in on both sides, and behind. Behind means here this is the cervix, this is the vagina, and here is the sacrum. So there is a ligament. This ligament is known as the uterosacral ligament. These two ligament forms the level 1 support. Level 2 is tendinous support or fascia. There are two fascia, arcus tendinous fascia vaginalis, arcus tendinous fascia rectalis. They form the level 2 support, that means in between. Here there are fascia. And lastly, the lower 1/3 or level 3 support are the perineal muscles. Perineal muscles, perineal body, the muscles of the perineal body and the muscles of superficial and deep perineal pouch. Now coming to vaginal cytology. Vaginal cytology, or that is the vaginal epithelium. There are 3 layers, and these 3 layers have been shown to be different, or their predominance changes depending upon the predominance of the hormone present in the female body. What is it? First, the superficial layer. These are the superficial epithelial cells. How we describe them? It is polygonal or hexagonal cells with sharp borders, with pycnotic nucleus, with abundant cytoplasm, and they are basophilic, right? They are superficial cells. Coming to the next layer. Next is intermediate, and lastly is the basal. First we will read the basal cells. This is the basal cells. These are basophilic, so we draw it by blue. Basal cells are mostly round or oval, and they have a large nucleus, almost occupying whole of the cell. They are known as basal cell. And in between them, in between the superficial and the basal cell is somewhat intermediate cell. They are neither, it is somewhat round or oval, and no sharp borders in between basal and superficial, with a nucleus, boat-shaped nucleus or the vesicular nucleus, which is pushed to the periphery. These are the intermediate cells. So, we read the epithelium of vaginal wall. Why it is important? Because the superficial cells respond to estrogen, intermediate cells to progesterone, and the basal cells in absence of estrogen and progesterone. In follicular phase of the menstrual cycle, when the follicle is gradually increasing in size, estrogen is predominant and there is predominance of superficial cells. Progesterone in the proliferative phase or during pregnancy, progesterone is high in female body. So, in vaginal cytology, we will see the intermediate cells, and in menopause, when there is no progesterone or estrogen, we will see the basal cells. This is the slide under microscope. where we see the superficial cells which are round hexagonal in shape with the pycnotic nucleus, the basal cells and the intermediate cells, right. This is how we see under the microscope. These are superficial cells, the intermediate cells and the basal cells. Where do we get these cells? We take scrapings from the lateral wall of vagina. This is the lateral wall, lateral. We take from the middle 1/3. We take scrapings from the middle 1/3 of lateral wall of vagina, and then we see it under microscope with staining, and then we will decide what is the mode type of cell, what are the predominant cell and what is the predominant hormone within the female body. Coming to vaginal pH, vaginal pH is acidic. Why it is acidic? That has an answer. The superficial cells, this is the epithelium. The superficial cells has abundant cytoplasm which contains glycogen, and this glycogen is acted upon by lactobacilli. Lactobacilli are normal commensals of the vaginal mucous membrane, and they form lactic acid. This lactic acid in the lumen will create acidic pH. So, during the reproductive age 15 years to 45 years, the pH remains round about 4.5. During pregnancy, it is somewhat more acidic and becomes 4. After menopause, no superficial cells. After menopause, there is no estrogen or progesterone, so more basal cells, no superficial cells, so no lactic acid, so pH will be alkaline. Before puberty, pH is alkaline, but just after birth, 10 to 14 days after birth, the pH somewhat becomes acidic. This is because of the maternal estrogen. Maternal estrogen will act on the female fetus, and there will be secretion of lactic acid from the superficial cells of the female fetus, which will lead to acidic pH of the female fetus. Coming to the vaginal flora, we have already told there is no glands, and this intact vagina, as there is no glands, it is resistant to gonorrhea and chlamydial infection, because these two bacteria mostly hide in the glands of the vagina. Intact vagina with no breach in the epithelium, they are resistant to gonorrhea and chlamydial infection. 3 types of infections are more common in vagina, that is Trichomonas vaginalis, Candida and bacterial vaginitis. What is the shift of vaginal flora? Lactobacillus, I have already told, it is also known as Dodder-Lenz bacilli, and they are normal commensal of the vaginal epithelium. If there is a shift to anaerobic bacteria, Peptostreptococcus, then Mobilincus, Porphyromonas, different anaerobic bacteria, then there causes a shift in vaginal flora, and there is some difficulties, there is some symptoms. What are they? They are, first is increase in vaginal watery discharge, right? Lactobacillus forming lactic acid, no lactobacillus, the bacteria has changed, so no lactic acid, pH will be more than 4.5. No, it will be more alkaline, no acidic. Number 3 is, if we give 10% KOH to the vaginal fluid, there will be fishy odor. It will give a fishy odor. This is known as amine test. And number 4 is presence of clue cells in cytology study. What is clue cells? The clue cells are nothing but the superficial cells studded with anaerobic bacteria. So, these 4 are known as the Amsler criteria. Amsler criteria. Any 3 of the 4 if present we give the diagnosis as bacterial vaginosis. This is a very common infection. I will not say it is an infection, it is a shift of vaginal flora, and this bacterial vaginosis, patient comes with watery discharge, thin watery discharge without any itching, without any other difficulties, but there is discharge. This is bacterial vaginosis. We can go for this criteria, we can diagnose, and as a treatment we will give metronidazole or secnidazole and also lactobacillus. It comes as sachet, lactobacillus or capsule we will give as treatment and it will get cured, right. Touching upon the vaginal cancer a little bit, vaginal cancer, what we need to know is this where it is lined by stratified squamous epithelium, non-keratinized, we have already told. So, cancer most commonly is the squamous cell epithelial cancer, squamous cancer. The most common site is the posterior, upper posterior wall of vagina. So, any growth in the posterior wall looking ugly, looking irregular, bleeding on touch, most likely can be vaginal cancer. It needs to be biopsied. This is squamous, most common is squamous cell cancer. Second most common is adenocarcinoma. Adenocarcinoma, now it has been due to vaginal adenosis, this is due to DES exposure in utero. In utero, if there is a female fetus and the mother takes DES, due to DES exposure there is vaginal adenosis, and from this from these vaginal adenosis cells there will be development of adenocarcinoma, which has now become very rare because DES we do not use nowadays, previously it was used. Adenocarcinoma most common site is anterior wall, lower anterior wall of vagina, right. So, that is all the vaginal cancer type, most common site, and if there is any suspicious lesion in the vagina, we will go for the biopsy. Now, we will discuss some of the MCQs. Here I have combined both the vagina and the vulva MCQ, just go through some of them. About vagina, which is not correct, you have to be very cautious while reading, which is not correct. It has mucus secreting glands, supply from uterine artery, lined by stratified squamous epithelium, pH is acidic, which is not correct. Uterine artery supply, yes, vaginal artery is a branch of uterine artery. Lined by stratified squamous epithelium, yes, it is correct. Non-keratinized, pH is acidic, yes, it is correct. 4.5, which is not correct, is the mucus secreting gland. Vagina does not have any glands. Next, length of female urethra. What is the length of, very important question, what is the length of female urethra? It is 4 centimeter. And diameter of female urethra is 6 millimeter. Acha. All of the following are supports of vagina. I have already discussed 1, 2 and 3 levels, de Lancey's levels of vaginal support. So, what is, all are the supports of vagina except, that means which is not the support of vagina. Perineal body, yes, it is level 3. Perineal diaphragm, levator ani or pelvic perineal muscles, the pelvic layer muscles, yes. Levator ani, yes, it is a support of vagina. Infundibulopelvic ligament, this is not a support of vagina. Infundibulopelvic ligament is actually the ligament which supports the ovary. This is the uterus and this is the ovary, this is the lateral pelvic wall. The ovary is attached to the lateral pelvic wall by the IP ligament or infundibular ligament or suspensory ligament of ovary. it has no relation with vagina. For hormonal study, cytological scrapings are to be taken from dash wall of vagina. Which wall? It is the lateral wall. Which wall of vagina? It is the lateral wall. Middle 1/3. Middle 1/3 of lateral wall of vagina scrapings are taken from here, and on the slide we do hematoxin eosin stain, and then we see it under microscope and go for cytological study. Next question, vaginal defense is present in newborn female for. We have studied it, the vaginal pH in newborn or before puberty it is alkaline, but for the first 10 to 15 days, before puberty means 15 years, this is alkaline, but for first 10 to 15 days due to the effect of maternal estrogen, the pH is slightly acidic. So, it will be first 10 to 14 days of birth. Theoretically, which infection cannot be seen in vagina? Yes, vagina does not have glands, no glands. So, gonococci, Trichomonas candida, chlamydia also, both will be the answer. Gonococci and chlamydia theoretically cannot infect the vagina, that is intact vagina where the epithelium, there is no breach or tear on the vaginal epithelium. With this we come to the end. These are the different questions from different examinations. References are from these books, DC Datta, Gray's Anatomy, Novak's and Williams Gynecology. So, thank you for your patient hearing. We will learn the anatomy of rest portion of the female internal genitalia in the subsequent classes. Thank you.